Kia ora, everybody, and welcome. I'm so glad you're joining us tonight for a conversation that I know is going to resonate with so many people, especially those who feel stuck, unheard, or simply not quite themselves in the current healthcare system. We're sitting down tonight with Dr. Leigh Willoughby, a functional medicine practitioner whose journey into root cause medicine began after years in working in anaesthetics, a specialty where you meet people at their most vulnerable and see firsthand how the whole body responds to stress, illness, and imbalance. That experience has shaped the way Leigh practices today with curiosity, compassion, and a commitment to understanding why symptoms appear, not just how to suppress them. In our interview tonight, we're going to explore what inspired Leigh's transition from hospital-based medicine to functional medicine, what surprised her along the way, and how she balances evidence-based practice with holistic tools that support long-term well-being. Welcome, Leigh. It's great to have you join us tonight.
Thanks very much, Deb. That was an extremely eloquent, very lovely description, and thank
Oh,
thank you very much for that.
you're
Um,
welcome. We would just like to set the scene and just let people know who we're chatting to and a little bit about where we're going. So it's great to have you on board with us tonight, and we're just really grateful for you spending some time with us. So I suppose the first question for our viewers tonight would be, what on earth inspired transition from anaesthetics to functional medicine? How did that work? How did that happen for you?
um, right. Well, when I was training in anaesthesia, I had done my first in the UK. We do 7 years training. That's the standard to get from a junior doctor to a consultant in anaesthesia. So you do 2 years as a sort of a senior house officer, as we used to call it, or it'll be a foundation year, 3 and 4 probably, in today's terms. And you do 2 years there, and you do 5 years as a registrar, and then you pop out at the end, and you are a consultant and on the specialist register. When after 2 years, a number of my colleagues, fellow well, we some of us were medical students together, but we were sort of our peer group. We were all in anesthesia, and we wanted. Some people were questioning whether they wanted to just carry on going for 5 years, because 5 years, it's really once you start it, you don't stop until you've finished it. And they were talking about opportunities to travel, because many of us had started university and hadn't really had an opportunity to travel. And so people were talking about going away with their intended, their partner, or maybe a friend, going abroad and just having a bit of a 6 months break to experience some other things, and then going back into anesthesia. And I started thinking about it as well. And I thought, well, that'd be nice. And I spoke to my husband, because I got married in 2000, and he's from New Zealand. And we decided to go on a bit of a tiki tour around the world. And he took a career break, and I basically just took a gap between one set of training and the next. So I didn't apply for the next stuff until I got back. And we went abroad, and we went to Africa, and that's quite an interesting story in itself, because that was when 9/11 happened. And then we went to Australia, and then we ended up in New Zealand for 2 months. And while we were here, my mother-in-law was taking some nutritional supplements. And I remember very vividly, really quite being very critical of my mother-in-law for bothering to take vitamins and minerals. And I was so ignorant at the time. And she turned around to me and she just said, well, Leigh, if I didn't take those products, I would not be able to run my business in the way that I do. And she piqued my interest, shall we say, retrospectively, because I didn't really think about it till I got home. And then that started a very intense journey of re-education, self-directed. And so alongside my registrar training, I started looking at the literature in nutrition, and I read lots of books by doctors who were using nutritional medicine. I was blown away by what sometimes what they were achieving for patients. And so I just carried on, and I actually ended up doing a research degree because I was so interested in these concepts. And I was actually teaching my fellow registrars and consultants about the downsides of statins when I was a registrar in anaesthesia, when I went, you know, before I went and did my research, and then afterwards as well. So I was already uh, well into the thick of the, sort of like the side effects of certain medications and why the biochemical reasons why that happens. So I was already starting to question whether these medications and whether these different interventions were really making a difference to people. So I was always asking the question, well, sort of, is it worth it? But also, why are people getting the symptoms that they're getting? Why are they ending up on the intensive care unit? What are the triggers? What are the reasons that people get, a storm of inflammation or whatever? So yeah, I was already asking those questions, and then I suppose people might think, well, why would anesthesia lend itself to doing that? Well, it's actually quite perfect, really, because like general practice, anesthesia is a generalist uh, specialty. And by that, I mean you cannot just concentrate your efforts on one organ system. You have to know everything about everything. And you have to know everything about every medication, because you will come across people with all sorts of weird and wonderful pharmaceuticals that you end up having to take care of in theatre, and know how they're going to behave and how you're going to try and enable that patient to be as safe as possible while they have their planned injury, which is the surgery.
Mm.
Yeah.
So you've had 20 odd solid years of thinking about where you want to go, and finally you are moving more and more into root cause medicine now. Is that
Yeah.
correct? Yeah, yeah, yeah.
Yeah.
So you've actually answered the second question, really, was how was your experience as an anaesthetist shape the way you practice functional medicine today? And you've explained, as you just did so eloquently then, about, as an anaesthetist, you had to be aware of every condition, every body system, every drug. So really, anaesthetics in some ways was the ideal specialty to take you into functional medicine.
Absolutely. Yeah.
Yeah, because we often think about doctors going into functional medicine from other specialties, but I'm sure there's probably not very many anaesthetists have gone into functional medicine. What other doctors do you know that have, and what specialties do people tend to go into functional medicine from? Where would they generally step into functional medicine from? What kind of specialty?
I think there's a lot of general practitioners who have done
Mm,
that. And obviously I've said that they're already, um, generalists in that, they don't know what they're going to get through the door every day.
mm,
That's a bit like anesthesia.
mm,
And they have to understand a breadth. They don't necessarily know in a specialized level any particular area, but they know what to recognize as far as red flags, and being able to identify serious pathology and being able to refer them on to the right place. That's a real skill. Um, so general practitioners mainly, but I guess because I trained with the Institute of Functional Medicine, I have been trained by and seen that in the States, particularly, physicians tend to end up, so internal medicine
mm.
specialists, some cardiologists. Some of them are quite high profile and have been over the last 6 years, but they're, there are people who have, there is a sort of a whole sort of peer group, I suppose, of doctors across the world who probably had the same experience as me in a different kind of way, maybe, it wasn't their mother-in-law or whatever, but it's usually a family member. So what often will be the story as that either the doctor themselves was sick and got better through functional medicine, or that their relative was so ill that they went through all the standard processes and felt and drew a blank. And then it was only when they started looking at the root causes that they
Right.
started to be able to get them better.
Right.
Yeah.
Makes sense.
And that's really, I think that's the theme throughout. I think there are a couple of anaesthetists or anesthesiologists, as you would call them in the States, who are in functional medicine. Um,
But probably
so
not too many in New Zealand.
not that I'm aware of, no.
So what surprised you the most when you moved from your hospital-based medicine, shall we call it, to a root cause model?
Um, it's a really good question. I think there's some there's been some really big benefits for me, individual, like for me as a person. And I suppose that would be removing yourself from a high intensity, all day, all night type of acute specialty where your day night cycle is completely mucked up and you never get a normal week where you would get up at the same time every day and go to bed at a reasonable time. So personally, I think the surprise for me took about 6 months for me to realize how incredibly disrupted my overall health was
Wow.
within that model of delivery of care. So
Mm,
we ran a normal roster, a normal rota where you do 24 hours on, and then you might get some time off the next day.
mm.
Um, so that was problematic. You got used, everyone gets used to it, but you don't realize how much of a toll it takes on you until you remove that and you start to live normally in terms of how our creator, like wanted us to live, which is, that day night cycle and in tune with the light and the the outside world, if you know what I mean. Yeah.
It's
And there's
really
so
interesting that you chose that as your example, of the thing that surprised you the most. And it's a very personal example. I thought you might have said, well, I wasn't sure what you say, but and in a way, that's a really good answer because your personal experience and the application of that to yourself helps you understand some of the issues that other people might be going through as well, and how the same principles apply to everybody. So it's really good insight that's been like a foundational principle for you moving forward. So I really like that, and it's a
I think if I was going to answer your question more directly, because it wasn't really all about the actual job itself, I think I've been surprised at how quickly, I mean, particularly children will respond to root cause interventions. Um, and that's really, really rewarding part of what I do. So, sort of identifying the problems that are holding children back and showing those things to them and their parents and just showing them how to deal with those has been hugely rewarding. So it is it's an area of my sort of the way I work that is I feel really good about. There are some people who are incredibly sick. I suppose another one is like that what surprised me, I just the enormous tragedy that people live through, and how resilient people are. You with functional medicine, you do an incredibly detailed intake, and that takes you to places that you discuss that you may never discuss usually in mainstream medicine with the patient because there's little time. Um, it often there are very transactional interactions because you can never get to know somebody in that sort of, and it's not the situation where you might find yourself in an outpatient clinic or at the bedside or in a in an ED that's brimming full of people, you never really get to talk to people about their most distressing episodes. And it's hugely therapeutic for someone just to listen to what's happened to someone. That's the first thing. Um, we were taught in part as part of our functional medicine about the therapeutic relationship and how the that sort of interaction at conversational distance can be so powerful, because not only are you listening to that individual, but you're each entraining each other's biorhythms. So you're entraining each other's ECG and your brain activity as well. And when you are empathic and you're completely focused on that person, that is where the magic happens, because that person feels that you're listening to them. They don't just speak and notice you looking and nodding and stuff. It's more of an organic thing where they suddenly realize that someone's interested enough to listen to their,
And they
and
feel
that's
really
very,
heard.
and that's healing,
Yeah,
you know?
yeah.
And even just drawing people's attention to severe episodes of stress, whether it be psychological or physical, they may never have considered or joined the dots that, oh, that's why this all happened, because there was it's usually a series of events that layer on top of each other that cause harm to an individual because they just don't have enough of that resilience to respond. Um, and that just them understanding that there's underlying reasons for why they are so poorly can be so useful, so helpful for them. And you talk to them about, oh well, that's really interesting you said that, but have you seen that this happened and then this happened and then you had this given to you or whatever it might be. And that's a very, very important part of what we do, yeah.
Sounds amazing. And I'm just thinking now, if every anaesthetist across the world was able to tap into some of that, as you called it, magic, that interaction, that empathy, that really listening, if they had the time, if they had the skills, how different things would be. But obviously, right now, that's not happening for a number of reasons, and we might cover some of that later.
I
But
think I think if I could just say that I've worked with many, many different anaesthetists over the years, and I I I do think that there are some very special people in anesthesia, because you do learn that a lot of them have an absolute their main regard is for the patient, and that that they come out as unscathed and pain-free as possible. And that is a tall order sometimes. And to gain that patient's trust right at the beginning in a very relatively short space of time is a skill and it's a vocation. I think it's, you have to want to do that. You have to want
absolutely.
to have the intention of making that person's life a safer journey. Yeah. So I
If
think
those,
there are lots of people in, and I would say they're probably throughout the specialties. Um, but it's the whole model that needs to be scrutinized. It's not the individuals, it's the overall remit of modern medicine that is questionable at times. Yeah.
that's absolutely right. When they're coming in and they're doing a quick pre-op check or, a quick post anesthesia check, it's not their fault that the time is limited and the resources are few. So you're absolutely right. And they do have a lot of responsibility. And um, very often, people will thank the surgeon, but they don't always thank the anaesthetist. And, it seems a little bit when the weight of the responsibility is with the anaesthetist. So, yeah, good job all around. So, just moving on slightly and thinking more about your functional medicine, What are the most common underlying issues that you see in patients who feel unwell, but not unwell enough for traditional medicine?
That's a really that oh, I talk about this all the time, Dev. So when I explain to people, I probably sound like a stuck record if people have heard my other interviews, but there's two things that we look for in our practice. There are two main reasons why people get unwell. The first is that the person is lacking in something that is absolutely vital for normal function. And that's sort of like a deficiency state, shall we say. Now, it may not be a frank deficiency like scurvy or rickets, but it may be a subclinical lower level of a nutrient or sort of cofactor that leads to the pathways that use that being, working at a subpar level over time. Okay. Now, deficiency is one reason why pathways don't work properly. And if you want to break it down to pathways, then that's kind of one reason. The second reason is too much of something that shouldn't be there. So that's like a toxicity situation. And so if someone has been exposed to, wildly abnormal levels of heavy metals or glyphosate or EMF or radiation or, there's all sorts. Mold is really, really big problem in New Zealand. So all of those things you would put into the toxicity bucket. However, those two causes aren't just in the realm of the biochemical and the cellular. A lot of the testing that we do does look at all of that. And that's a really important contributor. But in the same way, deficiency of love, deficiency of connection, deficiency of purpose, those three things are really important as in the deficiency bucket. And then in the toxicity bucket, toxic relationships, toxicity of substances. If you're addicted to something that isn't doing you any good, all of those things fall into those two buckets. And so we look at it in that way. So aside from that, I suppose the two commonest things that I see are severe gut imbalance. So the gut, what's going on in the gut is absolutely critical to every single illness that you could mention. The gut is the center of everything. And the reason that the gut is the center of everything is because you have the most biologically important and active barrier between you and your environment inside the gut. Underneath that, you have the immune system. 2/3 of the immune system sits under the gut lining. So that's huge. You think about the immune system, you think about the lymph nodes and the spleen and the little bits of the lymph, the Kupffer cells in the liver and all of the other places where there are lymph tissue, or the tonsils, for instance. But the lion's share of the immune system is right under that barrier. So if stuff is not right in the gut, so whether that be an imbalance of the microbes, an invader, parasites, yeasts, pathogenic bacteria, or you've got a problem with the mucus production at the barrier, or you've got some other immune, like an autoimmune condition of the gut barrier itself, then you're going to have a big problem, not just for the gut, but systemically, because then that leads to immune system activation, and then that has a knock-on effect on any system you care to mention. And one of the major places where it has a big impact is the brain. So that's why everyone's talking about the gut-brain connection.
Yes.
The gut is just an outpost of the brain
Mm.
via the vagus nerve. So, again, whatever happens to the gut will affect the immune system, but it'll also affect the nervous system.
And you
So gut
mentioned,
imbalance is probably one of the most common reasons why people get sick.
right, okay. You mentioned it before you started just speaking for this segment about people having deficiencies, but they wouldn't on normal biochemical testing, they may appear to be within normal ranges. So the ranges that you do as a functional practitioner, are they personalized to the individual? How does that work?
Okay, so um
Briefly.
yeah, briefly, yeah. So we do a lot of measurement in the urine of pathway metabolites. So they're chemicals that are produced by different pathways. And that tells us about the adequacy of that pathway, whether the stuff that is needed for that pathway to work properly is there in the body. So we can take that and say, right, well, this person is deficient in vitamin B2 or vitamin B6. Those two are the very, very common ones. But it also looks at B12 status, um, biotin, coenzyme Q10, a whole bunch of other ones. What I find is that standard medical testing never goes near any of those nutrients. It never
Mm,
measures them. It will measure folate and B12 in the bloodstream. And if you wanted me to talk about the disparity between what you find in the blood for B12 and what might be meaningful for that person's overall function, that they're two different things,
mm,
okay? But generally speaking, the blood tests that we do in mainstream never scratch the surface of the really important nutritional factors that are necessary for normal function. So we measure the outward appearance. I often say we it's like having a warrant of fitness. So when you do a full blood count and a liver function and a kidney function, it's a bit like going for a warrant where they check your tires, they check the brakes, they check the exterior, like they don't take the engine apart.
no.
They look for all the important things on the outside of the structure to make sure that you've got a safe vehicle. But they never look inwardly at your engine's efficiency or if there are impurities in the fuel. They never do a combustion analysis of the engine.
Mm.
And the testing we do is more of a combustion analysis than a warrant of fitness.
That's a
Okay.
really good analogy. I like that.
I've used it for a long time. It is a
Yeah, it's
very,
really
so
good.
what I say is the testing we do is like a Formula One WOF,
Love it.
okay,
Yeah, yeah,
rather than a WOF.
yeah.
So, like, well, Formula One cars they have to be on the money, don't they? They
Mm,
know exactly what's going on with the engine and all the different components, the tires, the temperature, the dynamics of the vehicle. They know everything.
mm,
That means that they can get the edge on other competitors.
mm,
Whereas with the human body, we settle for a WAF.
mm. And it is very true. And I'm thinking of, quite a few patients, in primary healthcare who go back to the GP every month because vague symptoms that they're just not getting on top of, and the tests come back as normal.
Yeah.
Because they're having repeated WAF after WAF, but they're not doing the fine tuning, or like you say, the high quality oil change or whatever, fits into your analogy, and they're never getting to the root cause of the issue.
Yeah.
So, that your analogy fits perfectly well with that. That's really great. Okay. So, how do you balance? Obviously, you told us a little bit about your journey into anesthetics, but how do you balance evidence-based medicine, which is obviously your background, with the more holistic tools that you use in functional medicine? How do you marry the two?
Um, that's a really complex question.
We
So
love complex questions.
so I suppose evidence-based medicine, as I recall it, and it's a while since I appraised myself, but I remember the Venn diagram with three circles. Um, the patient's wishes and the patient's choice is part of that, and there is no more patient focused than functional medicine because we take it very the journey is extremely important, and their history, how they relate that history to you and what you conclude as a result of it is hugely important. And then giving them the opportunity to choose other options to try and address their problems is obviously that part of that sort of dynamic of being tuned into the need to fulfill patients' wishes. Yeah. But you then obviously looking at the evidence, and the evidence is not as remote as people think. So, for instance, the Institute of Functional Medicine that I started my training with in 2015, when I finally found a qualification that really resonated with where I was going, they are affiliated with the Cleveland Clinic, and they have been doing parallel research alongside the standard of care to show the benefits of the functional medicine approach compared to standard of care. So with diabetes or with other chronic conditions. And I have, it's a while since I've looked at that, so I couldn't give you, exact papers, but they have published to demonstrate that functional medicine, looking at all of those root causes, helps you to, if you address those root causes, then the body does the rest. So, and I suppose we, in terms of research, there is so much that is wrong with it. There, I remember going to a conference or several conferences where the ex-editor of the Anesthesia Journal, which is the highest impact anesthesia journal there is, and he stood up in Brisbane and said that 2/3 of what is published is nonsense. So, and it's nonsense because it's fraudulent. So he told that to a medical audience.
Wow.
And he said that there was going to be a lot of fallout from the realization because a guy in Devon in the UK, he's an anaesthetist, I think. Yeah, he is an anaesthetist. He's a very clever guy, and he developed alongside this other guy a fraud detector, shall we say, a very sophisticated data analysis model that could look at studies, and they literally look at the numbers and they can detect when those numbers have been fabricated. And they were finding really big hitter researchers,
Okay.
multiple papers, always the last author, like big research center gurus, professors and stuff. And I'm not naming names because I actually don't know who he was talking about because he wouldn't obviously say, but they were going to be breaking that these guys were actually fabricating some of their evidence. So when you're looking at evidence-based medicine, what is the evidence? And the evidence for me in my practice is, where is the patient now? They are n equals 1. And at the end of the day, n equals 1, the person in front of you matters the most.
Absolutely.
It doesn't matter what happened in America 10 years ago in a study that was 2 years long using a particular drug. Maybe it was against placebo, maybe not, as
Mm.
we've discovered that
Mm.
placebos are few and far between.
Mm.
Um, and you think, well, as long as you are listening to the patient, as long as you're doing reasonably well calculated practice, so you're thinking about, like, there's lots of medicines out there that are useful, and they're useful, and you know what the science is behind them, you know why they work. As long as you're mindful of all the downsides and how that plays into this particular person's situation, like if they've got kidney failure, you're not going to put them on a non-steroidal, that it's it's not that straightforward, obviously, all the time. But I'm just saying that medicine is uh, it's an individualized, that's what it should be. It should be an individualized uh, benefits and risks weighed up with the patient and with other colleagues so that, having multidisciplinary discussions with the relatives as well, because, I have this lovely, lovely little patient who's in her 80s, who's just ended up in hospital. She has had a history of breast cancer, and she's come through that really well. And she's ended up with gallstones, and she's had that before. Now, she got rid of those gallstones through natural means, which we could go into at some stage, but um, she's had another episode of gallstones, and now they've also discovered that she's got metastases in her skeleton. And you think to yourself, well, what would I want if that was my mum or my grandmother? What would I want to happen? Now, the mainstream, the medical system are saying, right, well, we need to take her away and do an ERCP, make sure that the stones are out, and then we'll bring her back and then we'll take a gallbladder out. And
But what does she
they've
want?
just told her daughter that the MRI shows metastases in the hip and in the ribs, I think, somewhere else. I can't quite remember. It's just very fresh. I've not seen the report or anything. And yeah, so that's a really complex thing
Yeah,
to weigh it up and think, well, is it worth doing that? And then when you add in that this lady does have an element of dementia,
right.
so you think, well, what's the right thing to do here? What would you put someone of that age through those
Yeah,
two procedures just because that's what you would do with other people? It might not be right for her. I don't know what's going to happen because I'm not in charge of her care, and I just she's in the hospital and they're going to do whatever is the right thing for her far now and for
but it
her.
comes back to what you said before, doesn't it, about her being at the center of all the decision making. It
Yeah,
should be about her, for her, because of her, not
yeah,
we'll do this, this, and this. I mean, this, and this are options, but if she doesn't want to choose those options, she's not dismissing them. It's her choice, whatever she decides.
yeah,
And let's hope that she does get some decent um advice about what is
yeah,
available and the ability to freely choose and not be pressured, because, well, we'll do this, we'll do these RCP and we'll take the gallbladder out. You're right, at 80 something, is that really what is needed, especially with Mets? What is the thing that she wants to do? So let's hope and pray that she gets a clinician that will really listen, which is how you started off your story tonight, isn't it? About really listening and really letting the patient be heard. We can really hope that for her. So um, just a couple of, I'm just aware that time's going by. So just a couple of really quick fire questions. And
okay,
the first one would be, give us the top two lifestyle factors that you find have the biggest impact on patient outcomes. The top two lifestyle factors.
Number one, spore-based probiotics.
Number
Number
two,
two, uh, cutting out carbohydrates.
carbohydrates. I thought you might say that. Okay. And maybe we can bring you back to discuss some of these at length in the future. But okay, so that's two good, she says, easy tips for people to consider. But obviously, one of the things that people, when they have to do something like this, like cutting out carbohydrates, they get really overwhelmed by the idea that that's going to be a huge change to their lifestyle because carbohydrates have historically, especially in New Zealand, formed part of breakfast, lunch, dinner, morning tea, afternoon tea, smokers, and they're a
Mhm.
big part of our standard diet. So, what advice would you, in brief response, give to people who are feeling overwhelmed by the idea of making such big changes?
The first thing I say is that this is not, it's what's the word, the phrase, it's a marathon, not a sprint. It's it's some you need to introduce these gradually because your body will not like it if you do it quickly. And
Mm,
the first thing that I do is I say, pick one meal a day, one meal, not all of them,
mm,
just one meal a day that you will change. And we concentrate on that one meal. Now, I have like a little ordered coaching kind of sort of series of things that I recommend to try and start to cut down the carbohydrates gradually. But now I've had the beautiful fortune of actually bringing on a nutrition coach into my team. And that's really great because the detail of nutrient density and practical application of what you're saying when it's so difficult for people to implement these changes, plus the fact, there's lots of really clever sort of food planning kind of platforms out there.
mm.
But what you inevitably, you can remove this and you can add this and but what you end up with is a shopping list that's going to cost the absolute earth. You're going to get a lot of food waste because you don't, unless you're really mindful of using leftovers and overlapping things and taking into consideration the size of your family and the times that you eat and when you go shopping and all of these things, it's very, very difficult to create something that's practical for people. But my nutrition coach, Cheryl, is utterly amazing at that.
Wow.
So I'm just really really chuffed that I now am working with her because that's the sort of time that's spent that I don't have to offer every individual. Sometimes I manage to spend a little extra time talking about how they might implement the changes that I'm suggesting. But most of my work is sort of that front end of what's wrong and how do we change it. But it's the coaching element, it's the delivering that information in
Food.
bite-sized pieces so that
Yeah.
people can implement it
Yeah.
that is really, really important.
And in a very practical sense as well. Because you're right,
Yeah,
shopping up front costs money, which puts people off. And then if they're only making one meal with the ingredients and then the
yeah,
ingredients get wasted, it puts people off. And
yeah,
then, I think I read somewhere in my role as a diabetes nurse specialist that people tend to stick to about 10 meals. And, every couple of weeks we just rotate through the 10 meals. But if those 10 meals are no longer really have got the right nutritional values attached to them and you've got to do 10 new meals, whoa, that's as overwhelming as major
yeah,
surgery for some people.
yeah,
So, and it is the coaching that helps with that. It's the
yeah,
skills to do it. You still got
yeah,
to do it, but it's looking at it through a fresh pair of eyes and having the stickability to making it
yeah.
practically work. So I think that's great. And yeah, I think I'm excited to hear that. That's great. So what What changes do you see early on when people are, when they finally address the root cause rather than treating symptoms? What are some of the early changes that you might see in their health?
Um, so if they've got gut symptoms, we can often quite quickly see some changes happening with, say, uh, abdominal pains, bloating, but mostly to do with the bowel habit. The bowel habit seems to normalize. If they've had chronic constipation or they've had intermittent diarrhea and constipation, that's quite common, People never know where they're at, sort of thing. So those things change sometimes really early on in the piece. I think there are full body experiences is what I call them. So these are the really hard nebulous kind of symptoms that no one can really put their finger on in mainstream medicine. That's fatigue, anxiety, poor sleep, body pain, uh, just it's just like it's every system is not functioning, is functioning subpar and suboptimally. And I'm just trying to think there's some others as well, but those full body experiences, in my experience, are to do with energy pathway problems. And when you start to address that, it really makes a change for them. So they might just find that suddenly they're able to sleep a bit better,
Wow.
or they they're starting to notice that they don't need a nap in the afternoon. Um, they yeah, it's a very subtle, gradual change usually. And we would normally start to see results within, certainly within 8 weeks. We'd start to see quite considerable drops in their symptom scores. So we do a very specific symptom score that, it can be anything below 30 is acceptable, but anything above 30. Now, I've got some patients at the moment that were scoring originally at 190. And that's right across the board with all of those energy, emotions, weight, GI symptoms, musculoskeletal. It's right across the board. And a lot of, I suppose the other thing that is quite noticeable is chronic pain as well. So especially joint pain and stuff can often start to really improve early on. So I've got a number of women who just struggle to do exercise because they're like aching, and then that's another thing that can really respond quickly. I suppose the other thing is mood. And there's this one really big finding that that I often get is people are really, really low in vitamin B6. And that's never measured in the bloodstream, or virtually never anyway. But we measure B6 status in the urine. And it's a pathway. So it's not like, it's not a waff, it's a pathway thing. So if that pathway isn't working properly, then you will see it and you know that they haven't got enough B6. So because B6 is really important for both the production of dopamine and serotonin, if you've got no B6, you're going to have extreme, or that you are likely to have extreme mood and all sorts of other things, because dopamine affects everything: coordination, movement, cognition, everything. So brain fog, that's another full body
Biggie.
kind of experience that I
Yeah.
haven't mentioned. That's another really common sort of, just the clarity of thought has been lost because they can't make decisions anymore. And that's that whole like full body energy pathway issue because of lack of something that's really needed.
And it sounds so simple when you couch it in the terms you have done, but often these women, especially, have been going to the GP for years, thinking there's something hormonal related, or they just can't put the finger
That's
on it.
so common. And at
And
the moment, I've got a patient a lady who is in her early 30s, mid 30s, sorry, who's been told she's in perimenopause,
yeah,
has been put on HRT,
oh dear,
and like when we did the testing, found all these different issues and I'm like, why are you? Hormones are a second tier thing.
yeah.
Hormones are affected by all the things we've talked about: energy, the gut, the immune system, all of that. If you get those right, then the hormones will sort themselves out.
And I'm guessing she
Um,
scored high on the symptom
yeah,
with
yeah, she did. Yeah,
symptomology.
I think she was about 165, but
And now, how is she doing now?
oh, she's really early on in the piece.
Okay.
So I saw her within 10 days of her starting the program, and she um, had had a couple of really good days. So, so that's another thing that can happen. Sometimes they'll have a glimmer of something. Oh,
Mm.
actually,
That's
there are days when
yeah,
I actually feel okay.
yeah, that's good.
And then there'll be a couple of days when they feel like rubbish,
But the hope is there.
But the hope, it gives them a bit of hope and then they
Yeah,
can keep going with it. Yeah. Yeah.
that's really good. Okay, so just two more questions for you. So, if you could change one thing about the current healthcare system, what would it be? You only get one answer here.
That's a really hard one. One thing.
Maybe in relation to what you're doing.
If I could change one thing, I think I would want to change, if I could, change the attitude of my colleagues who are in mainstream medicine who have it in their hearts to destroy people like me. That if I, because there are lots of doctors and nurses and other practitioners who have the patient's best interests at heart and are still the whistleblower. You know, they'll stand in the gap and speak up if there's a problem, which is what you want. That is the loss of that over the last 6 years has been catastrophic for public health, if you want to call it that. So a lot of people who are doing that are being persecuted because they're doing something slightly different. They're not standing in line and doing they're not following the usual pharmaceutically driven, pathway driven, or protocol or guideline driven medicine. And they're being complained about. Instead of saying, hey, why are you doing that? What evidence do you have? Can you teach us something? What is it that you want? Instead of inquiring about what people are doing in natural medicine or complementary add-ons to general practice or whatever it is, they're just reporting them to the medical council. And I suppose that's the danger, is that I suppose weaponizing the people within medicine to, it's a bit like what happened, like snitching on your neighbors. It's a really, people who do good work, like most of these people, their patients love them. They benefit from the interactions that they have with them. They don't have as many side effects. They're doing a blend of normal, regular medicine that is protocolized, and they're doing some other herbal or natural, nutritional, intravenous vitamin C, whatever, the things that might help them are being used. And these people have never had any complaints against them from patients. They've never caused any harm to anybody, but the profession sits in judgment. And, when you do look at the research, that the reality of research and how much of it is fraudulent um, and what drives medical decisions, then it's a stark, well, it's hypocritical to throw stones at people who are genuinely doing what they believe is right for their patients. So
Absolutely.
I think if that was the thing that sprang to mind first. There's a whole lot of other things, and
Yeah, and that's
there's
you know,
obviously some system problems that
yeah.
are huge and need to be there needs to be good leadership, and I think that's lacking at the moment.
And it's interesting that what your first response was around the reactions of other colleagues to the work yourself and others are doing in this space, because as healers we should all be working together for the better interest or the best interest of the patients. Doesn't matter, like the lady you talked about earlier. So the surgical pathway is one pathway, but there are other things that might equally be helpful to her or should be offered as alternatives. But unfortunately, it's very rigid, narrow, blinkered thinking.
Yeah,
And, it's almost we need this merging together of functional medicine and mainstream medicine, in my opinion. That would be the ideal, but there's a long way to go because both sides have got work to do. And um, at this point, it's probably appropriate to talk about our series, which we're going to be running over the
mm.
next few months, called Health Without Spin, where we're actually going to be looking at some of the issues that Leigh's mentioned tonight in terms of system issues, resource issues, um, issues relating to the legalities of practice and to limitations on practice, where good practitioners are being hauled over the coals for doing things in a particular way because it doesn't fit with the prevailing narrative. So we are going to be discussing that at greater length and in depth over the next few months, and we hope people will join us for that. But yeah, I'm interested to hear you say that that would be the one thing that you could change. It would be that interaction between mainstream medicine and functional medicine, and in terms of colleagues learning to trust each other and bringing the real heart back into medicine and nursing. And as nurses, we often discuss that, but it's the same heart that is lacking in not all,
Yeah,
but a lot of medicine. And we have unfortunately seen that following COVID, and we'll probably talk about that again at length in the future. COVID changed a lot of things for the public as it did within the medical practitioners as well. So,
mm.
yeah. So, just to finish off, one last question, Leigh. What's one thing that brings you joy outside of your work?
My family, my family, and being able to spend time. Just recently, I've been going to watch my daughter play volleyball, and I just recall that I really didn't do that very much when I was working in mainstream medicine, and so much has changed, but some of it's for a huge benefit, a huge it's gone for the better for sure.
Hmm.
I miss anesthesia, but I prefer my life now because I'm able to uh, be in charge of how I work and also see my children more often and participate with them and spend more time with my husband, who's suffered a lot over the years because of the sacrifice that you make as a medical practitioner. He woke up every time I woke up at 3 o'clock in the morning, you know. Um, so yeah, no, I think being out in nature as well.
And it's interesting that your answer to that question really brought us right back to, I think it was question number 3 when I asked you what surprised you most when moving from hospital-based medicine to a root cause model, and you brought that right back to that personal responsibility. I hadn't realized how out of control things had got because of the system I was in. And right now, it's the thing that brings you the most joy, as well as the thing that you noticed early on about how your body was not balanced. But now it's the thing that brings you the most joy. And it's the simple things in life, isn't it? Like taking time out with your family doesn't cost anything, but actually the payback is huge. So that's
Yeah.
absolutely wonderful.
Yeah.
So, is there anything else you'd like to add before we close tonight?
No, I look forward to all our discussions, Deb.
Yeah.
That'd be really great.
And for those people listening in on to our session tonight, if there's any particular topics about root cause medicine or functional medicine that you'd like us to perhaps consider talking about in the future, pop a note into the comments, and we'll have a chat with Leigh and see if she's able to perhaps give us some top tips in those areas going forward. And Leigh, how can people get in touch with you and your clinic to find out more about what you do, and if you'll be able to help them either where you're based or remotely? Just give yourself a shameless plug.
Shameless plug. Thank you. So my clinic is called Functional Again, and it is the website is functionalagain.com. We're in Gisborne, and you can have a look at our website and what we do. You can call us. The number's right on the front page of the website. Yeah, I've also got a link tree, which is like brings together everything that I have done and interviews and stuff into one place. And so I could let you have that for the links if you'd like, Deb.
Yep,
And then
that'd be
people
great.
can go and look up and there's some free resources on that link tree. So there's a couple of ebooks and a little bit of there's a lecture on there, and yeah, people
Excellent.
might want to go and have a look at that.
That's really good. Well, we'll put the link into the comments as well when we post this online. So that's great. So one of the things that you and I have talked about at great length over many couple of years now has been our connection with a higher spiritual being, um, Creator God we call him, and an understanding that we are not our lives are governed by somebody who's greater and stronger and who's got our best interests at heart outside of the health system. So are you okay tonight, Leigh, if I just close in prayer? Be
Absolutely, I
happy
am.
for me to do that. Thank you. Okay, Heavenly Father, we just thank you for this wonderful opportunity to chat with Leigh today, and just hearing about how when we look at the root cause of sickness and illness and ailments, that addressing those and not just treating symptoms can just bring us back into equilibrium. But we're also aware that following you and having Creator God in our lives also helps us get back to that equilibrium. So we thank you for your presence tonight. We thank you for your guidance. And we just ask that as people listen to this session, that they'll take what they need and they'll use it and apply it to their lives. We ask for wisdom, for grace and mercy. And we thank you for your guidance. And we ask all this in Yeshua's name. Amen.
Amen.
Amen. Thanks,
Thank you,
Leigh.
Deb.
And we'll catch up in our next session.
Yeah, look forward to it.